Okay, it's 9:10. Let's go ahead and get started. Before we start the panel discussion, I want to recognize all of the sponsors. Once again, we have Banner University Family Care and their awesome health equity leader, Kurt Shepard, who was part of getting the sponsorship and working with us on the conference, and Arizona Complete Health. And it's Amy Darpino, who is also the health equity specialist for that plan. And then, of course, all of the people who were part of the work team. And I am Jeanette Mallory, and I'm with Blue Cross Blue Shield Arizona Health Choice. And IHA and the fabulous team that we have with IHA and helping us with the design and everything around this conference and everything that they offer for improvement in health literacy. The next topic, the next section is from 9:10 to 10:45. It's going to be a panel discussion. Each panelist will give an introduction. If they have room after their 20-minute introduction or within their time frame, they have 20 minutes to give their presentation. If they have time within that to answer questions, they will. We will hold a group Q&A at the end of the three panelists' presentation. I will monitor the chat on behalf of our panelists, and just one change in the agenda. There's Melissa Elliott had an emergency, and so she sent her director, and he will be presenting on behalf of Area Agency on Aging. The first panel, the panel discussion is all around the community and trust and how we build trust in the community, and we're looking at different communities. The first one that we're going to hear from is Johanna Molina. The name of her presentation is We Serve, Build Trust, and Collaborate with Compassion. She works for Maricopa Department of Public Health, and I will turn it over to Johanna, and she can give her introduction and her presentation.
Good morning, everybody. Hope you're having a wonderful day. Thank you for inviting me to present today and also be part of this panel and the guests also that are joining us today. So I'm going to share my screen and then we'll go ahead and get started. Let's see. Okay. Are you able to see my screen?
Not yet.
Okay. So let me see if I can get out of here for a little moment. Let's see. Let's see. All right. Okay. How about now? Can you see it?
Yes, thank you so much.
All right, thank you. Well, let me start with my presentation here. And again, thanks for joining us today. I'm Johanna Molina with Maricopa County Public Health. I'm very honored to be here this morning and to be part of this panel, and also to hear the rest of the speakers and the participants to learn from one another and to share some of the knowledge that we have gained throughout the years. So with that said, today's presentation is called How We Serve, Build Trust, and Collaborate with Communities. I have been with the county for 16 years in Maricopa County, 14 of those in the communications office as a Spanish-speaking PIO. My background is in media. And then the last 2 years, I have been in charge of the immunization equity program. And this came out after COVID-19. So I'll share more about those experiences because I think it's very important how we build trust with the community and how much time it takes. So with that said, let's jump into our presentation. So in this conversation, I'll be discussing the following. what we have learned throughout the years, how it starts, when we meet stakeholders versus the partnerships, and what it takes to build trust, how much time it takes to build that trust, and why it's important to continue when it comes to building trust. So what we have learned throughout the years, which is the first point here. So working in any field requires working with people. So in government, it takes a little more effort since stakeholders may not see the need to work with government. They may see, well, it's government. They're reaching out because they need something from us. And so we need to make sure that we have people in mind instead of an agency, just the name of an agency. So there's a lack of trust from people from the community. So we need to make sure that we're addressing people properly. Also, partnerships is a two-way street. It must be a win-win situation for both of us. That's what we have learned throughout the years. Also, don't reach out only when we need something from the agency. A lot of the agencies think, well, you're only calling me because you want me to do something for you, right? So keeping in mind that, we need to engage him, we need to be real. It is a relationship that we're building and it may take time. And it's not only check a box and we're done with you. So how it starts. So for us, working with the county for so many years, and I have learned that when approaching the stakeholders, we need to have a real interest in learning about them. Keeping in mind that we're building relationships with people, not necessarily with the building, not with the name of an agency, but they're real people. So we need to be talking to people. Also, we are hiring people. We need to hire people that can relate to have those strong connections in the community that represent the government and that we look like them. When getting to know the stakeholder, we have learned that it's important to learn and spend time getting to know what they do. And what is it that we do? We can share that experience with them as well. And it's okay to listen only and don't ask for anything. We need to find some common ground. It's a relationship that you're building. So asking ourselves how what we do relates to the work that they're doing. And it takes time. We need to be patient. Sometimes it may take years because it's a relationship. Things don't, you just don't wake up one day and we have a relationship with somebody, right? It's the same thing when working with other agencies. I'm going to give you an example. In all my years in Maricopa County, when I came 16 years ago, I already came with some relationships that I have built in the community. So in 2009, we were hit with the swine flu or the H1N1 pandemic. So at that time, I started meeting with some partners that we had already a relationship with. And we just wanted to keep them informed about the local situation in Maricopa County. At that time, we were not closing events, schools, or businesses, and we never did. But, we needed to make sure that people were listening to the local message, and I'll tell you why. The first case of the swine flu or the H1N1 flu appeared in Mexico City. So here you can see a picture of the Mexico City completely empty, which is very unusual for such a large, city. So people local in Maricopa County were hearing the news from Mexico City, and they were asking why is in Arizona or the county not closing any events. It was close to Cinco de Mayo. I remember clearly. So we had to find ways to connect with this community. The case in Mexico City was not the same thing here in Maricopa County. We didn't have any cases. We were also monitoring everything, but we didn't have any cases. So our response was very different. So we took some time to explain and meet with agencies. We did some, assessments. Who do this group, rely on? Who are the trusted sources for these communities? So we know the faith-based in the Latino community or Hispanic community is very strong. So we reach out to the Catholic Diocese at the time and also the Mexican Consulate. And I brought some media, Spanish-speaking media, to meet and explain what the local situation was. So we met with them and they felt, well, the door is open for them to call us with questions, right? So that was the first thing that we ended up doing. Soon enough, we were building the relationship with some of these agencies that we already had at some point, but now as a government representative, and they started doing PSAs for us in English and Spanish at this time about getting the vaccinations, in this case, the flu vaccine. You can see here is one of our first PSAs that we did with one of the bishops, the local bishops here in Maricopa County for the Catholic Diocese in English and Spanish. And the message was, I'm getting my flu shot, you should get yours, in English and Spanish. By getting the flu shot, I protect you. And when you protect yourself, when you get your shot, you protect me, because that way we can get together and we don't have to cancel anything. And we never had to cancel anything during the H1N1 pandemic. But this was a great example of how coming together, kind of coordinating the message, using the trusted sources in the community, them being our spokespeople. That was the message that we wanted to convey to the community. And those PSAs were ran before services at some of these churches, and also in the lobbies of some of the other agencies. Okay, so as a result of meeting with partners and stakeholders, we created a coalition to serve hard-to-reach populations. And this was only to keep people informed about the pandemic at that time. After the pandemic kind of fade away, we continued the conversation, and even beyond the pandemic, we brought other topics: heat, flu season, back to school immunizations, you name it. There is always something to talk about in public health. So this coalition has no other interest but to keep people informed and to share information about what we are doing in public health. We're not necessarily asking them, you need to spend this amount of time doing this, or you need to do this for us. It comes when they see the benefit of sharing the information with the community. Okay, so what it takes to build trust. Just going to continue with the same example. This coalition started during the H1N1 pandemic, and they saw the benefit of continuing the conversation. So this coalition is called Building Bridges to Health now, and we have about 30 to 35 agencies that are regular on our calls. During the pandemic, it was a weekly call. We have doctors, we have our nurses join those calls and share information from a medical perspective. And then later on, we continue the conversations, bringing other guest speakers as well, even allowing the same agencies to share what they were going through in their own communities. So this is just one of the pictures of the early on meetings that we hosted and when we formed the Building Bridges to Health Coalition. So we kept meeting virtually, in person, and finding ways to work together to serve the communities that were hard to reach. This is an example of one of our meetings about a couple of weeks ago, where we, with yes, people don't like to meet, but they also want to have a common goal. So we created the annual Preparedness and Wellness Expo, and we united all of our efforts to bring preparedness and trainings and also wellness screenings to those underserved populations. And we have people in various languages coming in, sharing information from Spanish, ASL, Asian Pacific community, languages. So this is an example of an outcome of this, having this coalition. So this year we were celebrating our 14th annual Preparedness and Wellness Expo. We had our first one last weekend on Saturday. And I'll share a little bit about that because we skipped one in 2020 because that's when we had the new pandemic, COVID-19 pandemic. So this group started with the H1N1 pandemic back in 2009. We continued the conversation all these years, and we got hit with another pandemic. So we skipped the get-together and the big events, but it gives you an idea of how we continue the conversation. So this picture on top, it shows one of the latest Preparedness and Wellness Expo we hosted. And we usually hosted at community colleges or malls, some schools that are big enough. This is only the briefing prior to opening the doors to the community. All of these people that you see in this picture are agencies and volunteers that were ready to work and serve the community. Okay, so this is before the actual opening of the events. The ones at the bottom, you can see these are real pictures from this past weekend. So it's diabetes testing, we have some blood pressure checks. We had dental screenings. All of this is not possible without the partnerships of different agencies, because we don't do it all. We're just kind of a glue that bring people together, but we partner with a lot of these agencies. Okay, so before the pandemic of 2020, COVID-19 pandemic, we used to do just one event, huge event for the community. After the pandemic, we started going to communities and go do grassroots efforts and bring 2 or 3 of these expos a year. So this past weekend, we had one of them. This year we have 3, and they're smaller gatherings because they're hosted by those partners in their own communities. So we bring smaller resources, but we're really targeting those communities that may not have access. And I'll explain more in a little bit. So this coalition also has helped us, again, during the COVID-19 pandemic. They were part of our efforts to reach those underserved populations. So our continued communication help, build the message for those communities, either the stay home message, the wear your mask, or, even the vaccinations, who's the priority groups and why. So people may not want to hear from government, but they want to hear from people that look like them and speak like them and they trust. So here's some examples of people, that were actually in our PSAs. You can see representations from the younger generations, also people with disabilities, Latinos, African-American community, other ethnicities, some faith-based communities. And they did PSAs saying, sharing their information about why we needed to either get vaccinated or stay home. Here's another example during the stay home, mandate that we had. We partnered with these agencies again. Thanks for technology. We had it all of our meetings via Zoom and Teams and, virtually. And that did not stop us from creating some PSAs, even, with their own home, their video home at home. So with their own phones. And they recorded the message, and then they send it to us, and we put PSAs together, and we post it on our social media channels. And we did combination of languages, and we posted on our English and Spanish social media channels. Here you can see some of the examples. For example, here is the deaf specialist and sharing, why we needed to stay home, the message. Also some other languages, and also we have multiple of these PSAs, either with different stay home, vaccinate yourself, or wear your mask, whatever the message was. Again, partnering with those agencies help us to be engaged and educating the community in multiple languages. Here's some examples of it's time to get vaccinated. So here, the first photo, you can see some of our outreach with the faith-based communities. For those who are local, we have an area in Maricopa County, which is called Maryvale. And a lot of those, hard to reach populations may be ingrained with their larger populations. So they felt that they were left behind. There was no way that they could make appointments, no transportation, language barriers, no access to technology. So we partner with some of the faith-based agencies in the area, and they help us spread the message. We walk with them. We distributed flyers. The nuns were walking and distributing the flyers and inviting people to come to their church because the vaccine was going to be available. Same thing, we did vaccinations at some of the, we meet people where they were. So if they were at work because they were essential workers, we will go to them. Here is an example of a meatpacking company where we did vaccinations for COVID, and we have interpreters. Here you can see the person in Swahili helping interpreting for this employee. The same thing with, again, walking the streets, volunteers, posting flyers, talking to communities that may be underserved, inviting them to come to events where we were going to be, and even answering questions. Do you have any questions about the vaccine? Do you know that we're going to be in your neighborhood? Do you know you don't need to book an appointment? Just come as you are. So those are some examples that we did during the COVID-19 pandemic, how we leverage the relationships. And how much time does it take basically to build trust? Well, it never ends. It's a work in progress. Partnerships take a lot of time. people leave agencies. They're not always available, or they move on. And then we need to start again from scratch. The agency names stay, they hire new people. We need to start with, building those relationships again. And sometimes the priorities or the vision change for the stakeholder. Agencies take breaks. A lot of these agencies that we partner with, they're nonprofit. So they have only time of year that they have higher employees than others. So they take breaks. Summer is a low turnout for calls because we know that they're on breaks. Also, they have a different way of supporting us. They may not be on every call, but they know where we are. We can call them, they can call us, and we can ask either to share a flyer or, share something with the community, and people are willing to do it. So why should we continue to build trust or continue building trust? Well, some of the lessons that we have learned is that things don't move as fast as we want. We need to communicate with partners so we don't lose them. If we just call them one day and we disappear for 6 to a year, then those people may not even be there anymore. So we need to embrace the opportunities and, for example, the momentum that we have after COVID-19, the pandemic, to grow and expand. We in public health recognize that there is still a lot to be done as a result of the inequities. And we have formed several programs, and one of them is the new program called Immunization Equity, which is the one that I was referring to early and that I'm managing for the last 2 years. So this program is responsible for working with communities that are underserved, that they have lack of access to vaccines, they have no medical insurance, there are language or transportation barriers, mistrust in government. And the goal is basically to connect them to immunizations, nearby clinics, either for the low income or, to our own clinics. We have 3, soon to be 4 clinics in Maricopa County, and also bring vaccines if needed. We work with vendors and with our own strike team, and we do community events since 2021. We started during the pandemic, going to, the homebound people and the communities. Then they transitioned the strike team to be more in the community doing these events for hard to reach populations. And keeping in mind that we also need to do education. Vaccines are not only for children, also for adults, and they prevent disease and outbreaks. So we needed to bring more than COVID vaccines for adults as well to the community. This is the team that I work with. So at the Immunization Equity team, we have worked together and putting together kind of our mission and vision that aligns with the department. And this is exactly what it is. We serve and build trust and collaborate with communities with compassion. So if you can take anything out of this, because it's a long mission for us, right, to remember, is that we serve, we build, and we collaborate. Okay, we don't ask people just to do things right away. We need to serve them, trust them, and build a trust, and then collaborate with them. And we meet people where they are. Our mobile clinics, immunize people with disabilities. We go where they are. Deaf and hard of hearing, we have some interpreters. Also the non-English communities, we go either to consulates, churches, or the parking lots, wherever people are and partners are willing to host us. We also continue bringing vaccines to essential workers, from farms to ethnic grocery stores. So these are some examples of during the COVID-19 pandemic, how we went to, mobile units, went to the farms and worked with those managers to make sure that they were allowed to get vaccinated, open doors for us as well. And they will bring people by buses and get them vaccinated and get back to work. They were essential workers, so they couldn't stay home and they couldn't take breaks to get vaccinated. So this is another way that we did it. We also continue building trust, by having flyers in multiple languages, and also translated all of our consent forms and also multiple languages. Here's just an example. Nowadays, we have an average of 20 events, community events per month with our Immunization Equity team. And they range from different locations. We go to them and we do different vaccines, not only the COVID vaccine, but also do flu. We do hepatitis A and B, HPV, Tdap, MMR, shingles, for people who are underserved. Again, don't have access to medical insurance. They don't have access to transportation, language barriers, you name it. So here's just an example of some of the ways that we continue building the trust, because we didn't leave after COVID-19, right? We stayed, and we continue to stay, bringing other resources, in this case, vaccines, to the communities. Just to give you an idea of how much we have done with our immunization equity program in 2022, our strike team did 190 community vaccine events. We administered more than 16,000 vaccines that included COVID flu for all ages and other adult vaccinations. We also work with vendors. So we did 24 community vaccine events with vendors in 2022. And they did over 900 vaccines, only COVID and flu vaccines for all ages. So overall, in 2022, we administered 17,149 vaccines in the community, going to communities that are hard to reach for the same reasons that I previously explained. So with this said, I want to say, how we started with this conversation with the conference. Trust in healthcare is driven by past experiences, communication, cultural beliefs, and values. So we must take the time to meet people where they are, getting to know them and serve them by taking into account their beliefs and values. And by doing so, we're able to build trust and collaborate for a healthier community. So thank you so much for listening today. This is part of my presentation.
Thank you, Johanna. We'll go to the next panelist, but I encourage people to put their questions or comments in the chat, and we will have time after all three panelists present to address those questions and to read the comments. So thank you very much. Our next presentation is Scott Hawthorne-Waite, and he will be introducing himself, giving his presentation, and also if there's time for questions and answers within the next 20 minutes, he will be able to address those. If not, he'll wait to the end of the presentation, all the panelists present, and then address your questions. Thank you. Take it away, Scott.
Good morning. Thank you for having me. What an excellent participant conversation that we're having. Like Johanna said, I am Scott Hawthorne-Waite. I'm a social worker. I'm the Director of Care Coordination at the Area Agency on Aging Region 1, which is the one for Maricopa County. If we'll talk a little more about if you're watching us from a non-local place. But we have been around for 49 years, and we're known as a trusted resource in the community. All of our programs are COA accredited. Our information and specialists are all certified. We are a behavioral health agency. We also are certified to bill Medicare, and we have contracts with several access plans, which is Medicaid for those of you outside of Arizona. We are a private nonprofit, 501c3, but we do receive federal, state, and local funding. And last year, we served over 122,000 people here in Maricopa County. As you can see, we're part of a national network of area agencies on aging. In fact, everyone in the United States and their territories is covered by an area agency on aging. If you are looking outside of Arizona, you can either Google it, or you can call any area agency on aging, and they can give you the intake info for another one. As you can see here, our map of Arizona, we're in Maricopa County, right in the middle, the red county, and then Pima County near Tucson is in southern Arizona. The other more rural counties have formed councils of governments, and they are the area agency on aging. So you might see them with different names. If you look on the left there in the blue, Mojave, La Paz, and Yuma County, they have formed the Western Arizona Council of Government, and they are the designated area agency. So sometimes they may have different names, but they do serve most of the same programs. So most of the programs I'm going to talk about are core programs that are available in all of the over 800 area agencies in the United States. You'll see also that Region 7 serves the Navajo Nation, and we also have an intertribal area agency on aging as well. Who do we serve? Well, of course, we serve older adults because we're the area agency on aging, but we also serve elder refugees, We have a large AmeriCorps program. We serve victims of late life domestic violence and elder abuse, people with disabilities, residents of nursing homes, persons with HIV and AIDS, and also family caregivers and grandparents raising grandchildren. And I'll go into each of those a little bit more in depth as we move along. So our programs and services are divided between our direct service, which is what we do in-house, and that's our behavioral health with counseling, our benefits assistance, case management, et cetera, are done in-house by staff. But most of our services are subcontracted. In other words, we don't make the meals at the senior center or run the senior center, but we contract with them for services. We don't provide the actual we're not the agency that provides the worker to assist the client in their home, but they're a contracted agency with us. Most of our subcontracted agencies have been with us for decades. I've been with the area agency almost 30 years, and most of them we've worked with all of that time. So we have a really trusted relationship with them. They understand our philosophy, and they're able to deliver that to our clients. General categories we're going to talk about today, and there'll be more specific info on each one, is our information and assistance, our family caregiver support, elder rights, life enrichment, and our home and community-based services. Many times our services are referred to as non-medical home and community-based services to differentiate us from long-term care, Medicaid, which also is home and community-based. So if you see that, that's usually more of a nonprofit program. Our information and assistance is our 24-hour senior helpline. Our 24-hour senior helpline gets over 50,000 calls a year. It is staffed by social workers. The majority are bilingual English, Spanish, and it's the central intake point for most of our programs. So if somebody needs Meals on Wheels or caregiver support, they want to know how they can get transportation to a senior center, or they're having issues with their Medicare, or what have you. All of the calls and information go through one central information and assistance, our 24-hour senior helpline. We also have caregiver resource zones in libraries throughout the county. We found libraries to be a really good place to reach caregivers, and we have some promotional bookmarks that work perfect with the library. So we're in 30 libraries countywide, and like I said, it's a great place to reach out to folks in general, but family caregivers specifically. Our benefits assistance program is called SHIP in other states, the SHIP program. And what that is an unbiased source of information for Medicare and for other retirement programs. Open enrollment for Medicare enrollees is coming up in October, and that's a very busy time for us. People can call in and talk to a benefits counselor or meet one of our counselors at a community location. There's over 20 of them. Or whatever we can do, they can come into the office. But as you know, you see a lot of advertisements on TV. There's a lot of information out there about Medicare. It's difficult really to find an unbiased information that's not funded by any of the health plans. So we have all of the information on Part D prescriptions, on Medicare Advantage, and on supplements, with the goal of having consumers make their own choice from the information. Also, our Senior Medicare Patrol is funded by Medicare, and we have folks who are trained to give presentations in the community about Medicare fraud, about protecting your Medicare number, to review the billings that come in every month. Maybe there's an error, maybe it is fraud, but to let people have more ownership of their benefits, protect their identity. One of our largest programs is our SAIL program, Senior Adult Independent Living. That has about 4,200 homebound clients here in Maricopa County. All of them have a case manager who sees them at least every 3 months. And those are services such as the Meals on Wheels, a little bit of housekeeping, personal care, minor home repair. These are more intermittent services. They're for folks who are living independently, want to stay independent, but need a little bit of help in order to make that happen. So it might be homemaking maybe once every 2 weeks. The home delivered meals, of course, are during the day. But it's really, if you think of aging services as a continuum, these are more folks, more the first call. We're often the first time they've met with a case manager or a social worker, or have even asked for help. So we start with clients, and as they move along the continuum and need more services, we help them apply for long-term care, Medicaid, or whatever's correct for their situation. You can see also APS, Arizona Adult Protective Services Care Coordination Program. We carved out some special funding for clients who are referred to us from Adult Protective Services. They are our most vulnerable. They really need immediate attention. We have 2 case managers who only respond to referrals from Adult Protective Services. Many clients need biohazard cleaning. We have clients who hoard, and we do have a nationally recognized hoarding specialist. So there's more to a lot of the issues than just going in and cleaning up. There's a lot of mental health issues involved. There's some need for some follow-up maintenance so things don't return. But it's a very interesting program. And clients who are referred to us by APS, a very small number are referred again to APS. So we know over the years that partnership that we've built with them and trust between the 2 agencies has really benefited thousands of clients. We are also a large provider for HIV Care Directions is our program. You wouldn't maybe think of that for an aging program, but we're very large and we serve a vast majority of clients. But that is the largest case management for HIV in Arizona, and they do both medical and non-medical. We also are the central eligibility for all Ryan White Part A services, a lot of housing information, health insurance, information and training on PrEP and PEP and other things. Again, as people with HIV and the disease has changed over the years, so has the agency, but still responding to many folks and even older folks with HIV. Our care transitions program, and a care transition is anytime you move from one setting to another. When people move from one setting to another, it's the opportunity for negative things to often happen. Sometimes people arrive at the facility, they don't have the medications from the hospital, whatever might happen. Our care transitions program is with Mercy Care, which is a large Medicaid and Medicare provider in Arizona, and we do care transitions for their clients leaving acute care settings. And the goal of the care transitions program is to avoid readmission. A readmission to a hospital is when you're discharged, but you go back within 30 days. It isn't that people did that intentionally, but there was no disincentive. And so now when a person leaves the hospital and comes right back, the admitting physician and facility aren't able to charge as a new event or a new patient. So we've worked on care transitions using a model by Eric Coleman, and we have reduced their readmission rate to under 10% for all of their clients who are out of the hospital. Our Family Caregiver Support Program started in the year 2000 when the Older Americans Act was reauthorized. We're serving 500 families right now, family caregivers caring for an older adult, 60 or older, or any age with a dementia diagnosis. They had to update the policy a few years ago because we had people in their 40s and 50s with dementia who otherwise wouldn't have qualified for the program. So most people, when they call into the agency, they might not know the words, but there's caregivers who want to know what's out there. They may say things like, I need a break, I need some help. And so calls come in through the Central Senior Helpline. They're assigned a case manager, and we assign the case managers regionally, and they go out and do a full assessment on the caregiver and the care receiver. One of our challenges is that we have 2 clients, right? And so we give respite, which is a brief interval of rest, a timeout, a break for people. And we do that 3 different ways. One is through the contracted providers I talked about, using our agency model, where we can contract with an agency that would send someone out 8 hours a week, certainly not to take the place of the family caregiver, but to give that caregiver a break to do whatever it is that recharges them. Some use that time to take a nap because they can sleep uninterrupted, but whatever that person feels they need. It's usually 2 4-hour shifts, but it varies. We can make some exceptions if temporarily they need a little more help. But again, it's just to support the family caregiver. They're assigned a case manager. We're able to assist them through the process and give them a break in their caregiving duties. We do that, like I said, through the agency model, but we have another program that we started 15 years ago called Friends and Neighbors. It's a consumer-directed care program. And the way that works is we talk with the family caregiver and we ask them, well, do you have any type of respite now, or how do you do that? And many people have a friend or a neighbor, a friend from church who wants to help out, but they don't want to ask them. They don't talk about the payment and everything. So we try to formalize that up a little bit. We tell the family caregiver, go ahead and pay that friend or neighbor to care for your loved one, just as respite care. There's timesheets and receipts, of course, to fill out because we're sending money. But the caregiver pays the neighbor 8 hours a week, the same, $16 an hour, submits the timesheet to us at the end of the month, and we reimburse the caregiver. So caregiver hires their own worker and we reimburse them. It works very well in more rural areas of the county where traditional agency models are difficult to staff, or maybe somebody needs respite at 7 in the morning to go to church. It's very difficult to get the traditional agency model to respond, but your friend or neighbor could. It also helps for our folks from other cultures or non-English speaking, where they can hire somebody from their own community, which just makes really good sense. We also use adult day healthcare centers as respite. We contract with 12 adult day healthcare centers in Arizona, in Maricopa County. They're like a senior center, but they are a secure setting. There's more staff to participant ratio, and there's an RN at each center. So we use that a lot for respite. You can imagine being a caregiver, being overwhelmed and stressed, and here comes the van to take your loved one to a center that they want to go to. People love to go, where they get recreation, socialization, they do bathing. There's a nurse to give them their medications, and that's twice a week. People can go have their loved one go twice a week to the adult day health center. Anecdotally, people tell us they feel their loved one is doing better, that they're a little more cognitively stimulated because they're spending the day at a center instead of just staying home. We have a voucher program also for an educational voucher. Sometimes caregivers want to participate in an online support group or a conference for caregivers, but they're unable to arrange respite. We have a voucher program just for that. We have support groups throughout the county. Some are in Spanish. There's one that is just for men, and there's also an LGBT group. Pre-COVID, we did forums in the community regularly. We're going to restart. We do things such as taking good care of yourself during the holidays, how to deal with your loved ones, a medical team, different subjects that are good for caregivers. And we're going to start those up again several times during the year. Our grandparents raising grandchildren, which is now more commonly called kinship care, because sometimes it's an older sibling or an aunt or an uncle. So if you just say grandparents, you miss some of those folks. We have a really good kinship care coalition here in Arizona, and our provider for kinship care is Duet. Duet is a community-based agency here in Maricopa County we've worked with for years, and they support grandparents raising grandchildren. In the 2000 census was the first time they gathered that data on grandparents raising grandchildren, and it was so high they thought it might be an error. But indeed, there are so many people who are raising a child who's not theirs. And I think when you hear the statistics, you need to know the numbers are actually greater. Many people don't want to identify what is happening with their family. We have a program called TruAlta. You may have heard of it. It's an international training platform for family caregivers. We have purchased unlimited licenses for folks in Maricopa County, where people can go on to the platform and learn information on various diseases, on tips. We have Teepa Snow, who did some good caregiver videos for us. It's a great way for caregivers to get information when they have the time to get it. We've had excellent feedback. And you can just Google TruAlta or TruAlta AAA, Area Agency on Aging /Phoenix. But if you Google TruAlta, you'll be able to see there's no cost to sign up, and it's really a good trusted resource. We do a lot with elder rights through our DOVES program, and that is for late life victims of domestic violence. I think many people, especially if you're not in social services, might think that that's something that typically happens to a younger person or maybe a person with young children. But we know that abuse, neglect, exploitation happens across the whole lifespan. So our DOVES program does a lot of community education and awareness. They have a mobile advocacy van where they go out. We have support groups in the community, and obviously they don't publish where those are. When clients qualify, we have emergency housing and traditional housing and interim housing. We have an apartment complex here in Central Phoenix that we bought, and that's for folks once eligible, are able to stay with us up to 2 years while they get back on track. Some need to file for divorce or for benefits or go back to school. They're assigned a case manager. They live with us for up to 2 years. Our legal assistance we offer through the Arizona Senior Citizen Law Project, and that's a project that's been around for many years, a well-trusted resource. Our long-term care ombudsman, and again, these are services that are available at all area agencies, excuse me. An ombudsman is a Swedish word for negotiator, and what they do is respond to identify, investigate, and resolve client concerns and protect clients' rights who are living in a nursing home, an assisted living, or a group home. And you can imagine if you have an issue regarding care, you may not want to discuss it with a person who's not the family, the funder, or the facility for obvious reasons. There's an independent person that you can talk to about any concern that you have. And that's the Ombudsman program. Like I had said earlier, we are a licensed behavioral health agency, and our Eldervention program actually can send counselors in-home to work with seniors, usually 6 or 8 sessions or so, and then the counselor will help them find more ongoing services if they need it with their insurance. But they do a lot of talk in the community on Safe Talk. This is Suicide Prevention Month. They do a lot of talk on that. Mental health first aid. RX Matters is taking care of your medication. And also their home meds and our hoarding. We do have a hoarding specialist, works with clients who hoard and trying to get people who are still active in the community to work on their behaviors before it gets to the point of adult protective services. We are certified to bill Medicare and Medicaid in many plans on behalf of the client directly. It's very difficult to get a counselor to go out and make a home visit. There really aren't too many who do it anymore. So it's a really unique service that we have. And we've referred some of our family caregivers as well. Sometimes they have some issues regarding placement of a loved one and obviously grief. We had the doctor talk about refugees, and we have a refugee program, but it's for older adults. Many folks come here, the children go to school, they learn languages, people more our age are working, they're out in the community, but they brought their 80-year-old grandmother with them. Well, that person has different issues and different learning issues. Immigrants or refugees get benefits when they arrive, but if they need to be a citizen within 5 years, and there's a lot to becoming a citizen, not just learning the English, but the civics exam. There's a lot to it. And we have clients who perhaps aren't totally literate in their own language. So we have pre-literate teachers and volunteers to teach folks. We have a computer lab. They have their own senior center where folks get together. And also we provide transportation. And we have 17 countries represented in the program. And the case managers for that program were refugees themselves. So we have folks from Cuba and Vietnam and Congo and Burundi, which we need here, of course, for language and culture. It also gives our agency the ability, and we have staff that speak 20 languages. So it really is a unique situation here in Phoenix that we have such an international base here at our agency. We have an AmeriCorps program, and it's the only one in the United States that is seniors serving seniors. All of our AmeriCorps members are senior citizens themselves. Usually AmeriCorps, you think of people right out of college or younger folks. What they do is provide casework and supportive services for the social workers. They do some friendly visiting and calling, deliver food boxes, and other supportive services. Through our health promotion in the senior centers, they're changing a lot more towards health promotion. It's trying to get younger people and to do things more active. And you can see we have a health promotion manager, and they do all of these classes at many senior centers, a matter of balance, chronic disease, self-management, and diabetes. And they do a pre and post test. And it's been amazing how people have really improved their health by doing simple programs at the senior center. Well, the pandemic changed everything for everyone, and it surely changed our services. We had a lot of older folks who were on our program, but they didn't want anyone to come out to their house. We had folks who were just afraid to go to the grocery store and had no other resource to use the internet to order or what have you. So we developed Operation Hope, and that's where we delivered enhanced food bags to people with fresh fruit and meat and vegetables. We have a goods to home to take cleaning supplies to senior HUD complexes. Elder shop, where we can actually grocery shop for people. We don't pay for the groceries, but we do the shopping. Telephone reassurance, and Elder Connect, where we were able to give people a life alert type set up for 2 years at no cost. A lot of these programs are still going, but they're not accepting new clients as things have changed with the pandemic. I know I talk fast and I went through a lot of information. The takeaways are there is a time in every life for our help. Our 24-hour senior helpline, 264-HELP, is available. If you live outside of Maricopa County, you can contact any area agency to find out the intake information for where you live. Thank you so much for your time, and I believe the slides will be available as well if you need further information. Thank you.
Thank you, Scott. And please put your questions or anything that you would like to learn more about in the chat, because there's going to be plenty of time after these presentations for Q&A and discussion. So our next presenter is from Phoenix Children's Hospital, Jill Hecker Fernandez, and she will have 20 minutes for her presentation and then be open for additional Q&A with the entire group. Thank you.
Hi, everyone. Am I on? Yeah, I'm on. Okay, there I am. Hi, my name is Jill Hecker Fernandez. I've been a pediatric nurse for 33 years. I'm so excited to be here, and the diversity of the presentations is absolutely fantastic. We are going through culture, we are going through age, we are going through families, and I'm really excited to be here on this panel with colleagues here in Arizona. I've been in Arizona for 7 years. So I don't think I'm an Arizonian yet. They tell me it has to be 10 years, I think is the limit. So I'm not sure about that, but maybe you guys can help me with that in the chat. My focus here is to talk about trust with pediatrics. And one of the main things, I was a clinical assistant professor for 19 years teaching pediatrics to nursing students. And one thing I used to always try to explain to them is that they're not little adults. And so we can't really generalize everything that we do with them in comparison to adults or other age groups in the population, because each part of their life is so very different. They're growing and developing, and there's different phases and stages that they go through. There's also different phases and stages of families as well. When you're having a new baby, then when you're having a second baby, when you have toddlers versus teenagers, everything is very different. And I used to explain to them that trust is very important, because when we enter a patient or family's life, it's a privilege to be there. We are privileged to share their experiences and their life and what's going on with them, especially their life views. And the main part to remember is that they're experts in their own lives, and we're the visitors. We're coming in as visitors. And so to gain trust with them is really important, because we're there for one period of time. Maybe we're going to maintain that relationship, but sometimes it's, just a one-time visit, or it's a one-time hospital admission. And when we talk about care, we talk about with children, obviously they're usually healthy children. So we talk about a lot of preventative care, and we have to gain trust within that part. We talk about acute care. So when they have that ear infection or urinary tract infection, that's one issue. And then chronic care for those kids who have chronic health issues like diabetes or asthma or cystic fibrosis, for example, if we want to go to an extreme. So I think we need to understand also that the main part about this is that we have a triad here. We have the provider, we have the child, and then we have the family. So we're working in kind of a triangle kind of loop. And 1 in 4 parents have low health literacy. So when we're talking about health literacy, 1 in 4 parents have low health literacy, and that affects their ability to use health information and to make health decisions for their child. So trust is a key part in that relationship as we're trying to encourage them going through those phases of child development and child life. And we know that if we have low health literacy and we can't make good decisions, we're going to have poor outcomes, and we're going to have challenging outcomes. And that's going to be something as simple as nutrition, or it could be something as major as not doing the right thing with asthma medication or administering asthma medication and maintaining, control of asthma in a child, which causes increased admissions. So the objectives here, I probably take a little bit of a different approach, but I want to talk about the pediatric population. I want to talk about family-centered care, because family-centered care creates an approach of trusting relationships with healthcare providers. We also have to recognize, again, children are not small adults, and we have to care for the family as a system if we're going to reach the children and get good health outcomes in pediatric care. And then also I want to talk a little bit about developmental levels, which I know goes back to a basic foundation. However, I think understanding child development is key in anything that you're going to do with a child. So you know where they're at and how they're going to interpret your actions and what's going on with them specifically and how you interact with them. I think one major thing to say when we talk about these objectives is that if they can't understand what we're doing, they can't trust us. So patients need to trust the provider, but also the provider needs to trust the patient. So we have to really have those ears and listen to what they're telling us so that we can trust what they're saying, and then we in turn can respond to those issues. When I looked up the definitions of trust and what is trust and how does trust work, I found these terms. They came from the article. The reference is listed there on the bottom of the slide. But trust is believing in the ability and strength of someone. So gaining trust, as you see the remember we used to do the falling thing, the person would fall back. Are you going to catch me? Are you going to catch me? It's the ability and strength of someone. So they want to know that we have the ability and strength to help them, but we also want to tell them they have the ability and strength to learn and take care of their health needs. And that's part of trust. Fidelity, they want to know that we're going to continue to support them. We're not going to just disappear. The systems that are put in place are there to support them and take care of them. They want truth when we talk with them and dependability. They want to know that we're dependable. Competence, again, we want to show them that we have sufficient knowledge to help them. If we don't have that knowledge, we're going to find someone or someplace or somehow that does. And we want to be able to show them that we have good judgment and skill sets that can help them to move forward with their healthcare. Honesty is trustworthiness. We have to be honest at all levels and completely transparent. And then I think caring, there was one definition that came out as I continue to research and think, what are the best ways to explain this? Preservation of human dignity, promoting healing, demonstrate a regard for standards of our profession, what we do as our calling, and our position in healthcare. Because I think our position is another challenge when it comes to trust, because sometimes the families and children see us as here, but we want to make sure we all come together so we're here at the same level. There was a quote in an article that I read, and I'm just going to read it. It was from a parent, and it says, "I wasn't upset by my child's bad reaction to the treatment. I was upset because no one told me it was a possibility beforehand." And therein lies the trust issue. The other example I always try to give is when I did my master's thesis, which was the experience of a broken heart, talking about the experience of giving birth to a child with congenital heart disease. One of the parents in one of my interviews, she said, I'm afraid to cut my baby's fingernails with a nail clipper. And I'm going to hand you my baby, and you're going to take that baby and you're going to open up their breastbone and you're going to mess around with their heart. And I have to put all my trust and faith in you that that's going to be okay. It's a huge responsibility when we enter these patients' lives. And so trust is a huge piece to that. When we talk about development, I usually look at two theorists. So psychosocial, which is Erikson. Some of you may be very familiar with it, so this may be a little bit repetitive. But I just want to talk a little bit about the stages, because if you listen to the definition of the stages, it kind of brings forward how we create trust in everything that we do, even though we're talking about infant to early teenager, early adulthood. So if we think about stage one, we know that the environment is secured. How? By the caregiver. The infant develops trust because the caregiver responds to the needs. And that's what we do with all of our patients and families, right? We're the caregiver. We respond to their needs, and we do it consistently on a steady basis without doubt or fear. In stage 2, when we talk about autonomy versus shame and doubt, our goal is to promote self-sufficiency. We do this in patients and families every day, regardless of age. And that's how we promote trust. We create self-sufficiency so they know they can do things, and we support them as they learn how to do things and do it well and maintain their health. And that's in a secure environment as well. So the environment is also very important because we want to maintain a secure environment where they feel safe in asking questions, safe in telling us when they don't know or don't understand. And again, each one of these phases brings out something that we do every day and every hour with patients and families. In stage 3, initiative versus guilt, we guide their initiatives and interests. So when they take the initiative to learn how to use their own inhaler at the age of 13, we guide that, we promote that, and then they can see that we trust them to know that they're able to do that, and we create success for them, which is very, very important. As we go through, we think about praise for accomplishments and identity versus role confusion, industry versus inferiority. I think understanding development, especially when you're interacting with a child, is key, because if you go to their level where they're at within their psychosocial development, you're going to understand better the things that they do. Like, for example, when you talk about a 6-year-old, if you can think back to that time of in your life, which for me is a long time ago, but that's the time when they're like, why? Well, why? Why does that well, why? Why are you gonna, why do you need to take my blood? Why do you have to look at my poop? Why? But you have to explain to them why, right? And that creates trust because you're giving them honest answers of exactly what you're doing, how you're going to do it, and why. The second theorist that I like to talk about is Piaget, and this is cognitive development. And we have to be really aware in children about how they're developing cognitively. Okay, so when we think about the sensory motor phase, this is the sense, they're getting senses, they're touching and feeling and looking and trying to figure out their world. And they use their language for demands, right? I want, I need, give me. Okay. And then pre-operational, they start to have some symbolic thinking, but they also develop language. This is a huge part of language development. They use symbolic play. In pediatrics, one way that we gain trust is play. We sit down on the floor with a stethoscope and a doll, and we show them and explain to them what we're going to do. We let them perform the same things on that doll or teddy bear or whatever it might be in order to gain their trust, to show them that here's what we're going to do, here's the equipment I'm going to use, and this is how we draw them in and gain that trust. And that can be in any community setting when we're doing vaccinations. That can be getting ready to do pre-op education for surgery. The next phase, the concrete operational, this is where we have logic. We're getting a lot of logic. We're able to think a little more logically. We're able to follow what's going on and why it's happening. And so your explanations and your discussions are going to be focused on that child as well as the family. But the child needs to have their conversations with you as a provider, asking about their vaccinations. Why do I need to do this? What's important about that? Why do I have to use my inhaler? Why do I have to do a peak flow test to make sure that I'm breathing okay? Why do I have to count my carbohydrates? Because I have type 1 diabetes. And there are concrete rules. They understand the differences between height and weight and volume, but they're concrete rules that they're used to following. And they begin a more in-depth understanding of how they need to work through things. And then formal operation is that older part. They're getting abstract concepts. They're able to solve problems. So they want to know how they can fix things, change things, and make things better for themselves, especially when it comes to illness or challenges within their life. That can be psychological, psychosocial, any of those types of things. And we have to be aware and be open and really try to listen to those words, listen to what they're trying to tell us. I think, describing how children learn and how they grow is really very important. The next piece we focus on in with children is family-centered care. And family-centered care, we use this concept. It's developed over time, but we use this to promote health and well-being of the family and the family dynamics. But we also allow a maintenance of control. We have to give the families control over their healthcare this is where we gain trust. And I'm just using this example, this picture here. We have, the parent standing there, the child who obviously is going through cancer treatment at some level. And to gain the trust as you're doing and saying and explaining things when you're concerned, about so many other issues. If you look at what's on the slide, it talks about respect and dignity. We have to listen to our patients. We have to honor their perspectives and see where they're coming from. We just talked about cultural issues. This becomes a huge piece in pediatrics because how people raise children and focus on children in different cultures is very different from each person. Information sharing, we have to be honest and provide information. It has to be unbiased. It has to be complete. We want to be affirming and timely and accurate because this is important for the families to be able to make decisions and maintain that control over their child's health care and their family's care overall. Participation, in pediatrics, we start teaching parents and families very early on how to change a dressing, how to take care of a central line, how to take care of a nasogastric tube. And we send them home trusting them that they can do this. And they trust us to give them the information they need in order to be proficient and successful in their care. Collaboration is huge. We do need to collaborate because sometimes we're not all going to agree on everything. We're going to be talking to families and we may not, meet eye to eye on a medication or a way to do things. And in that point, we have to, re-examine and think about what's going on. We have to use those tenets of family care, family-centered care to build that relationship with them, so that the trust is there, so that when we do have a disagreement or something doesn't seem just right, we're able to, take it a step backwards and look at it and come together and collaborate and make the best decisions for that child and for the family. Again, showing empathy is a big part of this too, understanding where the family is at that moment, because it changes so quickly sometimes for some of these families, is really important. And when we have the opportunity with family-centered care, when they come in for a vaccine or they come in for a healthy check, a well health check, we have to take that opportunity to ask those questions and be available to them with that trusting relationship so we can provide the information for the preventative care that they need, or elicit questions that may come from a child or a parent that they're really unsure how to ask. And so using those words and assessment tools and interviewing tools is really key to drawing that family in and sitting down and being present with them in their moment. Creating an environment of trust. We've talked about that in many of these different conversations here that we've been going through. And I think one of the issues here, a main thing, is to reflect on your own experience with the healthcare system. Sometimes when we reflect on our own experiences, it helps us understand and be that person, that authentic person, where, like in this diagram, it's explaining authenticity. I experienced the real you. I'm here with you in this moment. And they will sense that. Children sense it and families sense that. I think also when we talk about our actions, the way that we present ourselves, the way that we talk to patients and families, the way that we interact, how we make eye contact, putting ourselves at the level of a child. There's many times I've been in a patient room or in a consult, and I'll literally sit down on the floor, on the blanket, and sit down and make sure I'm at eye level with everybody in that room, because being at the eye level and being part of their environment is very important. Families need to trust. They also need to understand the inherent power of the patient and provider relationship. We need to make sure that we bring ourselves to their level so that they can trust us to really listen and be present. We also have to remember their past experiences in healthcare. And I always use an example about children who come in to have voiding cystourethrogram, which is where they have to have a Foley catheter put in, they fill up their bladder, and then they ask the child to pee. Now, there's two issues there. A child who's potty trained is not going to want to pee randomly without using a toilet. The other issue is that we're putting a catheter into a very private area for them. And in order to do this in a way that's kind and caring, we finally have realized that sedation is the best way to do it. A little bit of nitrous oxide so they relax, and we can help them to go through this procedure in a very kind and humane fashion. Some children that have had that procedure before, when they come in and know they have to have it done again, if they weren't cared for in an appropriate way with trust and gentle care, they will have a really traumatic response to what you're going to do. So always realize the perceptions and past experiences, also realizing the perception of the institution. You know, we are blessed here in Arizona to have a standalone children's hospital. There's only about 250 standalone children's hospitals in the United States. So for many people who live in specific areas, they don't have access to the level of pediatric care that we do here in Maricopa County and in Arizona. So realizing that as well is another issue, because when children go into adult environments, it's really hard for people to understand and relate to the developmental issues and the growth issues that need to be considered when we're communicating, talking, and caring for children. So we want to demonstrate that we have competence based on trust. So again, we go back to that caring, the fidelity, the honesty, and the competence. Communication with children and families, I just kind of elicited some of those things, but 7% is spoken words. And we talk about ways to communicate with children, and I come and say, oh, I'm going to put an IV in. And they're like, IV? And granted, I'm from the Midwest. So then they'd be like, oh, poison IV? I'm going to take your blood pressure. Why are you going to take something from me? So we need to find ways to use terminology that goes back again to that plain language that we talk about with health literacy, thinking about universal precautions and in health literacy, and watching how we say things, what words we use, the voice, the tone, and then our body language. Again, body language can be really key in conveying trust and conveying that we validate their experience and we validate their concerns. The family needs to trust the provider, and the provider needs to trust the family. So we need to treat every patient the same, regardless of who they are, whatever their history is, and think about some of those issues when we're interacting and how we communicate from a personal communication standpoint. When we communicate with families, and I'm not going to read the slide, but we want to involve all family members. So the child is included in that, no matter what age the child is, whether they're paying attention or not, but we want to reference the child in the communication and make sure that we're making open lines of communication, which is that one of the tenets of family-centered care. Tell them to write down things when you're leaving the clinic room, or you're doing an aftercare conference. Write down your questions. Let us know when we should come back and talk to you. Non-judgmental. We sometimes think, oh, that's not the right way to do that. I would never do it that way. But families have ways and means of how they do things and how they interact. Again, availability and openness, looking at your watch, staring at your computer, charting while you're talking to them, documenting while you're talking to them, or making it seem as though you're kind of, have to get to the next patient. You got to get to the next thing. You are busy. We have to maintain that availability, because if we're not available and we're not open to the patient and family, we have to make sure we have the time and the environment to promote that availability and openness. Respect and encourage feedback. Let them know say, tell me what you think. What are you thinking about this? How are you feeling about this? Let them be very honest with you, because their ability to be honest with you, again, brings that trusting piece back into the relationship between you and that family. Avoid assumptions about the core family beliefs and values. This can be very challenging. And of course, respect family diversity. And we just had a huge, amazing conversation about that for our keynote speaker. Diversity is challenging. And here in Arizona, we do have a lot of diversity. And we need to be very aware of that and understand how to interact with people of diverse cultures, populations, religions, sexual orientation, etc. And just be aware of our own judgments about those things, our own experiences, so that it doesn't get brought into that relationship with the patients and families. This is a quote from an article, and I think it's super important, because this is kind of what trust is: ensuring that the family's voice is heard first and last in their own words. So my main message, I think, with what I came to talk about with all of you, is that families are challenging. They're wonderful. They're different. Again, you're talking about a triad. So you're talking about a provider and a family and a child. And in order to get the best healthcare outcomes for those children, we need to look at the family and find out where they're at and promote the health literacy within the family. And the only way we're going to do that is by being present, accepting, open, available, and allowing them to see that we are really interested in how we're going to take care of them and what that care is going to look like. I think I'm going to end there. And so thank you for listening to me. I'm very passionate about what I do. Like I said, I've been a pediatric nurse for 33 years. I've been working at Phoenix Children's for 4. I've worked all over the United States in Connecticut, Florida, Tennessee, Arizona, Wisconsin. So diversity and experience is something that I really focus on. And I was always very careful with my nursing students to make sure they had those experiences so that they could bring those into their practice going forward. Thank you.
Thank you so much for your presentation, Jill. It was awesome. I'd like to now bring the other presenters live and have it open for Q&A. And like I said, you could either put your Q&A in the Q&A section or the chat. We do have a couple questions from earlier. First of all, I want to say we have a lot of really good positive feedback on, you know, the conference so far and how all your presentations have gone. One of the first things that I would like to read from one of our anonymous attendees is, Johanna, what would your advice for building relationships with organizations that have high employee turnover? You talked a little bit about employee turnover. Is there anything else that you would want to add to address this question?
Yeah, thank you. Thank you so much again. And to the rest of the panelists, great presentations. I'm learning something new every time. So thank you for sharing. And with regards to turnover, based on the experiences that we have, because I know partners come and go, right? People leave. So we need to start again building those relationships. Because we work directly with the agency and with their staff that is assigned to work with us. So it all depends of where a lot of the agencies that we work with are nonprofits. They're not all government. So we need to meet them where they are. Not everybody has the funding. Not everybody has a large, group of people working for them. And we got to understand that. That's why one part of my presentation was focused on getting to know them, who they are, what they do. Is there room for us to collaborate? If not, that's okay. At least we get to know who we are. But, having the door open for communication is key. So depending on what agency we're working with, it's how we can approach it. In my work, a line of work, we work a lot with the community itself. So a lot of the grassroots efforts, and they are nonprofits. They're not necessarily medical groups of people, and not necessarily government either. So we work with whatever they have. We tag along whatever services they have, there we are. So just meeting them where they are. I don't know if I can tell them, hire more people or pay them to stay. And not necessarily government has the funding to be given them every time either. One of the best relationships that I have built, I believe, is more on the common goal that what I have benefits you and what you have benefits me, instead of how much money do you have for me? Because the money runs out and you don't want to lose that time that you invested. So it's more about the win-win situation, understanding that what we have is a benefit for your community and what you have is a benefit for us.
Thank you. I just asked the other speakers too, if was there something around engagement with organizations that have high turnover that you would like to touch on or add to what Johanna already had said?
We've had a lot of turnover with our home care providers and folks who provide respite, especially now with the pandemic. But we've worked with our providers, which we've had for several years, to at least have a team of one or the other. So as a family caregiver, I know it's either going to be this person or that person to the best that we can. So I don't have to tell the story again. My care receiver already knows them, and that way I'm able to have respite because I trust that relationship with my loved one, and the worker is there.
Okay, awesome. Thank you so much, Scott. Let's see what other questions that we have. Johanna, could you talk a little bit about building bridges to Health Coalition and where the immunization events are being held?
Of course, yes. So this group again just came to be many years ago, and we continue to have conversations. It would be great to have a coalition that has hundreds and hundreds and hundreds of members, right? But we realized that in order to have those strong relationships, you may not need thousands of people on a phone call, but you may need 5 good or 6 good ones that will spread the message, and they have a lot of pull. They pull a lot of people for you. So we need those trusted voices in the community. And those agencies that we are working with have proven that they trust us, we trust them, and there's a relationship there. So we continue the conversation with them on a bi-weekly basis. It's only about an hour. We open the discussion, like, this is what's going on in public health. The numbers are going high, the numbers are going, going down. If it's COVID, it's heat season, it's super hot, there are so many deaths in the community, but these are the cooling stations that you can go to. So sharing all the knowledge and wealth of knowledge that public health has and what we do, a lot of communities find it really interesting, and that they don't know what we do sometimes. So opening the door for communication is always very beneficial. And that's what Coalition does for us, in my case. And also hearing from them, because we don't know it all. They are the experts in their communities. If we're not getting enough people getting vaccinated in this case, in specific groups or ages, why is that? We need to have that conversation and trying to tap into those areas. So having the door open for conversations for us in a bi-weekly basis is very helpful. And we only take an hour. I try to be very mindful and respectful of people's times.
Thank you. I'm going to go to Jill, because there's some comments where what you said had really resonated with people around being, a professional and a parent of a child with complex medical needs. And another person commented that she's an active supporter of pediatric health literacy and appreciates your commitment to ensuring we uphold health literacy for all ages. And then there's a question. Jill, what are some methods that you use to promote health literacy within your organizations?
Sure, that's a really good question, because if you look at the literature, health literacy it's exploded, obviously, just within the last period of time, because we've created this realization that this is a real necessary component if we're going to get good outcomes, decrease readmissions, and positive interaction with the healthcare system. Last year in October, we celebrated our first annual October is Health Literacy Month at Phoenix Children's. It was fantastic. We are trying to educate and promote health literacy throughout the organization with all providers. We participate from the Emily Center, where I currently work. We do new provider orientation, we do nursing orientation, and new resident orientation. So within those presentations, we talk about health literacy, we talk about universal precautions, and then Teach Back is a part of our education process. So all nurses are educated in Teach Back. Providers are also educated in Teach Back, and we use that as one of our points of assessment, is how we're doing as an institution. So when we did our Health Literacy Month, we had a lot of, we did every day, there was a quiz question. I'll put it like that. Like, what is the percentage of people that are health literate in the United States, and different things like that to try to get people to engage. And then, if they answered the question, they were put in a drawing for a big gift basket. And also they could also pass by the Emily Center for, a book bag or a t-shirt or things like that. So we were trying to really get people engaged. So we're going to do that again this year. We're in the planning phases of that, but that's kind of what we're trying to do as an organization. You have to get buy-in. Buy-in is the biggest piece, I think, to get that done throughout an organization, especially with one as big as Phoenix Children's.
Thank you so much. Those really good tactics, and especially in linking everything around Health Literacy Month and within the training of your providers. Scott, we have a question about does area agencies on aging programs vary from state to state?
They do. Some, of course, are very small and more rural and more info and assistance. But the core programs I spoke about, the non-medical home and community-based ombudsman, benefits assistance, family caregiver, you'll find those at all of the area agencies. But they do vary.
So it would be a trusted resource for people who live in other states other than Arizona.
Yes.
And let me ask you one more question. Here it asks, how does your team build trust, or how do you look at developing the capabilities to be a trusted partner?
We really need to build trust with caregivers. Many times people have been a caregiver for many years. They've never sought out any services. Maybe they didn't even identify as a caregiver. So I think we need to be open and honest, active listeners. We do what we say we're going to do. We also maintain healthy boundaries and confidentiality. Several of our clients live in the same apartment complexes and kind of talk and things. And so we make sure that we may not maintain the healthy boundaries. And again, it goes back to not just the social worker, but it's the providers that go out to the home that actually serve the clients, that they have to have that same philosophy that we have. We work really hard to make that happen.
Thank you. That's awesome. Was there anything else? I'm still looking at the chat. Was there anything else that any of you wanted to touch base on? Any other?
I see a few questions from me. One is talking about the media, and the other one about the volunteers. Okay. So let me start with the volunteers. So Maricopa County Public Health does have a program that is for volunteers, and thank you for that question. So I saw it on the chat. I'm like, let me try to find the information so I can give it to you. So the county's public health is kind of a large program department. So we have different programs. So one of them is the volunteers, right? The Medical Reserve Corps. So people who are interested, in being a volunteer as a part of the MRC, so they can either email or call. And one of the presenters later today is an awesome person who's going to present on precisely on kind of the care center that we call it. And the number that I'm going to put on the chat, or I can give it to you, is 602-506-6767. And if you're interested in becoming part of the Medical Reserve Corps or MRC with Maricopa County Public Health, you can call this number, and I'm going to put the email also, mrcvolunteer@maricopa.gov. And there is kind of a training. There is a kind of a form to fill out. You had to kind of do some trainings, and you had to do some background checks, because it's the safety of our community. So we want to make sure that we're serving with the best, and volunteers are always the best. So thank you for that question.
Joanna.
Yes.
I asked you that question only because, and I want to, yeah, because I'm part of the Medical Reserve Corps, and I volunteered during COVID in the COVID-19 call center. And when you talk about trust, the phone calls we received to that center were amazing in many different ways. But one thing I have to say about the trust part is some people were calling just because they just wanted to talk to someone and feel better about their situation. And Maricopa County Department of Public Health was able to put together a volunteer team in that place that was able to provide that to the community. And I felt so proud to be a part of it because that trust that they were putting in us when they made those phone calls was amazing.
Yeah, and thank you for bringing that up because that care center is still standing. It's not going to go away, and that's one of the presenters that you guys will be able to enjoy later. And one of the presenters about that, care center. And with regards to the media question, it was about if we use media, social media and all different kind of platforms to share the message. Yes, we do. It has to be very concise message. So we work directly with our communications office in public health. We just don't start putting messages all over the place. It has to be, a very concise message of what we want to say. So we don't start, we try to stop the rumors, not to spread anything that may be considered the wrong message or not an appropriate message. We hear our partners, we listen to them, we gonna share our message with them, and then we come together. Okay, well, how can we do this message that will be beneficial for the community? So we use radio, TV, social media. We have our own platforms in English and Spanish as well in public health. And obviously we do some other, like the text messaging if it's needed, or, next door, depending on who the audience is. And our partners, if they are kind of sharing the message, they use also their WhatsApp applications because it's a trusted venue for them. So they use other things, but with our message, which we always, are very grateful for.
And then Scott, you also put in the chat about your the senior helpline.
Yes. It's a really trusted resource, even if you don't want to make a referral, just to find out information. We have a lot of information on everything from Medicare to advanced directives to how to go to a senior center. So any questions, we encourage people, please, to call. It is 24 hours English and Spanish.
That's great. And I'm sure with the concern around social isolation and the impact it has had, that those helplines have really been a blessing for people feeling connected.
Yes, very much so.
So Jeanette, I see a question there about the barrier of families speaking other languages when trying to communicate. And at Phoenix Children's, we have a lot of unique ways to manage that because, again, just like our first presenter, we do have a huge diverse culture. And we get patients and families from all over the world, as well as all over the United States. We do have interpreter services on site. And so that's always available. And then if we don't have someone on site that can speak that particular language, we also have our little mobile robot interpreter machine, as I call it. And so that the providers bring that into the patient room, they dial the number, they get that person on the phone that speaks that specific dialect or language. And then we use that as a mechanism to make sure we can communicate with patients and families. From the Emily Center standpoint, when we're providing patient education as far as like care of the patient and discharge instructions, things like that, we do get requests for translation of documents. So for instance, we have specific booklets that we give out for nasogastric tubes or tracheostomies, et cetera. And we have the ability to, based on the patient situation, to make a request to have that translated into their language. We have the person in interpreter services will go and interview them again, because what the keynote speaker talked about is that we have to make sure that the patient can actually read and in their language and at what level. So that assessment has to be done. And if, for instance, they don't have the ability to read, then we come up with other ways to do that, which is using our mobile interpreter. I call it an interpreter robot. I know there's a technical name for it, but you know what I'm talking about. And also pictures. We work really hard to make sure that the patients and families get the information that they need. We also, in the Emily Center, the consumer health information specialist nurses, which I'm one of them, we can go online many times. And we just had a request for instance, lupus, a new diagnosis of lupus in Vietnamese. And we have sources and we have reputable sites that we can go to and get that information and print that out and then bring that to the family. We bring it in English and in Vietnamese so that the nurses and providers can see what we've given them. And then they can use that with the interpreter services plan to make sure they get the appropriate information.
Very comprehensive. I like the robot idea.
Mm-hmm.
There is a comment around interpretation services. We have a few minutes if somebody wants to address it. I know that there is training on how to deliver interpretation
Yes.
services, so it's friendly and
Mhm.
trustworthy and not robotic. And so in the comment, I would say that with whoever you use as a vendor probably has some of that training set up already to
Yeah.
provide it. And can you talk about how your staff, your qualified interpreters, are trained to be?
Sure. So when we use interpreter services and it's it's I used to make my nursing students go and watch when this would happen because it's a really interesting dynamic because you have the tendency to want to look at the screen where the interpreter is or look at the interpreter versus the patient and family. And so the way that they train is that you're speaking to the patient and family, the provider directly. The interpreter is in the background, then there's a pause, and then they provide that same information in the language, the native language of that person. And typically, when you, see if I can explain this right. When you speak a native language, so if your native language is Spanish or Portuguese or whatever, when you speak in your native language, you're more passionate. Your voice intonations come across a lot differently than when you speak in a trained language. So that's why sometimes it may sound robotic, but typically those people that are speaking, and Joanna, maybe you can address this too, but when you speak, in your native language, your voice intonations are different. For example, si yo empiezo a hablar español ahora, es diferente, ¿no?
Mhm.
Right? It's not going to come across the same. So that's one of the main things why interpreter services is so important and that we get native speakers typically. Sometimes they're not native speakers, but mostly they are. I don't know, Joanna, do you want to comment on that? Because I think that's really important.
Yeah,
Thank
I
you.
was going to mention too that part of our team when we are, building this trust in the community is also having hopefully staff that speak some of those languages because of the personal touch. And like Jill
Yes.
is saying, also the comment,
Mhm.
having the affections and
Mhm.
finding common ground. You look like me,
Yeah.
I can speak like you,
Yeah.
I can refer you to a joke from our country, right? And
Yeah.
people
Yes.
just loosen up and they
Yep.
open up.
Mhm.
So
Mhm.
that makes a big difference. So in our team, we try to do that. And not only because of other languages, even in English, we see this a lot in our events. We always try to have a coordinator on site for all of our vaccination events for immunization equity. So, and they are kind of helping people. Do you need a form, English and Spanish or other languages, or do you need help us filling out the form? You will
Yes.
be surprised how many people that speak the language
Yes.
don't know how to read, or the
Yes.
font is too small, or
Mhm.
they don't have their glasses with them. So
Yes.
all different levels of meeting the needs of the community, even in their own languages,
Yes.
or the word that they're reading, their level of education does not match. So we always have to have someone on site that can at least gauge what is it that these people need.
Yeah.
And people are afraid to tell you sometimes.
Yes.
So they spend a lot of time with the form, and we kind of train our team. Like if you sense something is off, it is off. Approach them nicely, kindly, and respectfully. Say, do you need help? How can I assist you? And people really embrace that conversation.
Well, thank you
very
all.
true.
We're out of time. If anybody wants to say, Scott, did you want to add anything before we close about the interpreters or anything? I didn't want to cut you off.
No, we are lucky that we have people here who are native speakers from all around the world from our refugee program. And again, it's not just language, but culture. And we
Yes.
don't
Yes.
approach everyone the same. And so we
Mhm.
rely on them as much for that as for language.
Great topic for another conference. Thank you all so much.
Thank
And
you.
you've been
Thank you.
fabulous, and the participants have been very engaged. So thank everybody for this. You're going to sign out and sign back in with the new link for the next presentation, which starts